Hello and welcome to Yodo. This information is about syncope or fainting. A special thanks to Dr. Harrison Stubbs, who provided information for me to present on the channel today. The information today is a discussion about a topic that can seem innocuous but may indicate a worrisome process is brewing or occurring. The what is syncope? This is defined as the transient loss of consciousness with spontaneous return to baseline. Syncope is derived from a Greek word that translates to interrupt or to cut short. Fainting and blacking out are other terms for a sudden collapse when a person keels over and just kind of conks out for a few moments. The acute reduction of circulation and oxygen supply to the entire brain results in this kind of a collapse. The person becomes pale, there's often a spasming or stiffening of the extensor muscles of the body, and thus the person might fall backward. But most will have such a brief episode of this spasm that they just simply go straight down. Think about how your body is structured. Your head is about 2 feet higher than your heart, and when something occurs, that the force pushing that blood up that extra 2 feet to your brain just isn't quite enough to make it that distance. Your brain is going to have a sudden glitch, and it's kind of like when your internet connection is lost to your computer, it's going to shut down for a few seconds. If you're seated, like your computer's resting on your table and you see that circle going around, you might just kind of slump over. If you're in bed, your eyes might roll back just for a brief moment as your brain kind of reboots. But if you're standing on a ladder or driving a car, you're not going to be able to maintain the control over your body, and you're not going to stay standing. You're not going to remain on the ladder, and you're going to fall. If you're in a car, you may wreck it. There's typically a fairly rapid return of the circulation and oxygen when the person wakes up, or they kind of just like come to, and it seems like it's pretty quick for most people. These events are typically brief, usually less than 30 seconds. However, by this time, the fall has occurred and there's likely been an injury. For some patients, there's a prodrome that may occur. There's get a little slight warning, and some people will describe having feelings of maybe dizziness or lightheaded. They experience a sudden sensation of weakness or acute fatigue. They might become sweaty. Some people can be forewarned by a vision or auditory sensation disturbance. The person's pupils may dilate a little bit. Their eyes are kind of going to roll over or roll back in their head, and it's like almost like they're trying to look backward. And that if there's a tip-off, for most people that experience that, they're later going to state something that it was quick or brief when that event occurred, and it happened so fast they couldn't act on it to protect themselves from the fall. They might say something like, "It happened so fast after I felt funny that I just went down." Or another common statement that they'll make is, "I just couldn't seem to stop it." After awakening or coming to, many patients will break out in that sweat, breathe rapidly, some will have nausea, and a few might even experience vomiting. Palpitations are typically reported. Many patients feel a bit dazed, and yet will report feeling almost nearly normal, but for possibly the injury that was sustained. When a person's blood pressure suddenly drops 20 points or more from their systolic pressure baseline, it may not be sufficient to get that blood up to the brain to perfuse it. This is often sudden when it's significant to this degree. But for some patients, there's a short delay of maybe 2 or 3 minutes after standing when that blood pressure systolic drops. For some patients with orthostatic blood pressure drop, there is not an increase in that heart rate. And if the heart were able to increase its beats fast enough, then even lowering the blood pressure would be offset by the frequency of those beats. This is how it's supposed to work. When someone faints and then comes to, please allow them to have just a few minutes of full circulation to their brain and kind of coming to before you try to stand them up. If their circulation was fully interrupted for long enough for someone to drop to the ground, it's best practice to let them acclimate for a few minutes at least before you get them up or sit them up, especially when they still feel a bit woozy. When your blood pressure drops, if you're laying flat, it's easier for your heart to perfuse all that blood than if you're standing or sitting up, because it has to push it up the hill, so to speak. So let them lay there for just a minute before you get them up. If the body has overreacted to a trigger and there was a sudden drop in the heart rate and or blood pressure that caused them to go down, that's just a natural response. The body wants to get that head lower so that the circulation returns immediately. Thus, that person falls and their heart and head are now at the same level, so the blood pressure doesn't have to be as high to pump it up. When you're standing or sitting, your head is higher than your heart. Normally, we have protective measures to prevent an acute drop of blood pressure. When these systems fail and a person faints, it indicates that there's a breakdown in that system. Something went wrong with the checks and balances. Let me back up and give some data about syncope. Statistically, the breakdown for a syncopal cause that is found is 10% of those are cardiac issues, 10% are vasovagal causes, 20% are because of an arrhythmia, and nearly 40% are due to an orthostatic problem. The remaining 20% are from any one of a multitude of other causes or a combination. But in nearly 30% of all syncopal events, they occur for no certain cause, and we just don't ever really find what happened. And so we're all kind of left wondering and hypothesizing about it. The lifetime cumulative incidence for a person is about 35%. So a third of all people will experience fainting at least once in their lifetime. It's the same across gender. And if you've suspected that the incidence increases with age, you're correct. Recurrence of syncope implies a cardiac or neurologic event is more likely to have been occurring. Morbidity and mortality of people that have recurrent syncope events with heart or neurologic causes is higher than for people who have recurrent events from a different source. Syncope makes up about 4% of all emergency department visits in the U.S., and 75% of those people will be admitted to the hospital. The rates of admission after a syncopal event increases with age and might be more related to the trauma that occurs from the fall than to determine the cause of the syncopal event. The cause might be innocuous, but the trauma typically is not. Because the events can be the herald of something ominous, rapid and full evaluation of the syncopal event is warranted. 50% of the people over the age of 80 will have that faint occur, and those people are going to be admitted to the hospital at that age group. Patients that reside in long-term care settings, such as an independent living environment or an assisted living facility, have nearly a 30% probability of syncope occurring to them across the years they live in that setting. Typically, most people are going to live in one of those environments for about 4 years. The average duration of stay for a nursing home is just over 12 months, and a quarter of people will faint at least once during that time when they're in a nursing home. There are many hidden factors to this, including age, debility, frailty, weakness, chronic disease, and for a certain number and kinds of medications that can lead people to be more apt to have a syncopal event. Falls in facilities are sentinel events, and this is discussed in a separate video. The information on sentinel events is extremely important, so if you haven't seen that, please review it. Nearly 40% of patients that have syncope will have trauma from the fall. 80% of those people will have some minor injury, and they don't seek or need aggressive medical attention. Severe trauma, such as a fracture or a head injury, occurs in less than 10% of people, and the data for severe injury correlates well with patient age and the activity that the patient was engaged in at the time of the event, for younger folks mostly. Because the trauma from the fall can be significant, and possibly for many, this might forevermore alter their health trajectory of that person, and for a few, the injury sustained can be life-threatening. So these are some of the reasons that the cause of the syncopal event needs to be investigated. Thus, soon after the syncopal event, a thorough evaluation is launched. Determining the cause is warranted as we want to treat this, if at all possible. There are many potential causes to these fainting spells. Many times, however, the cause is not determined, as I said earlier. The drop spell could be due to something innocuous and not likely to ever repeat, such an episode of maybe emotional distress, the sight of blood, or some activities, maybe standing too quickly or standing too long, or being in hot and a humid environment. These are just a couple of the many examples of when a person might have a one-time syncopal event that's not going to repeat and doesn't indicate a serious concerning health issue. The workup to determine the diagnosis involves a detailed history, a physical exam, and several tests are commonly done. Screening blood work of blood count and some other basic labs are typically obtained. Checking the person's blood pressure and pulse in both upper extremities while seated is advised because these numbers should match. An orthostatic evaluation is another non-invasive common test that is done to evaluate heart rate and blood pressure at the same time. Even though this is quite easy and straightforward, as a test, it can frequently reveal the important information and may lead to understanding of the cause. The patient is rested for a few moments on a bed, and they lie supine on their back. Their blood pressure and pulse are then taken with the patient lying, then seated, and then standing. Then those blood pressure and pulse readings from lying, seated, and standing are compared by the physician and evaluated for the abnormal response. Additionally, evaluation of pulse and rhythm is often checked with an EKG. Depending on the circumstances of the event, it may warrant further cardiac monitoring, such as a Holter or an event monitor, to be placed. A tilt table test, also called an upright tilt test, might be used to evaluate how the patient reacts with their heart during position and postural changes. Other tests include Doppler evaluation of the carotid arteries, an exercise stress test, an echocardiogram, which is an ultrasound of the heart to look at the structure and function of the valves, or possibly an electrophysiology study, an EP study, to look at how the heart electrical system is working. If the circumstances indicate other imaging may be done, like for a fall, they may be doing x-rays or CT of the head, and depending on what the circumstances of the fall, they may do the CT of the head not because of the head injury, but to help determine the cause of the fall. But that's not one of the more common tests. Certainly if trauma has occurred, there's going to be lots of tests and imaging. You're going to be looking for those broken bones or possible head injury, but not necessarily related to the cause of that syncopal event. Assessing the patient may call for a comprehensive evaluation that is known as a geriatric assessment, if that person falls into that age group and classification. This consists of looking in depth at the older adult's health with a goal to identify medical, psychosocial, and performance needs of the patient. Functional status is an important part of this particular evaluation. Cognitive evaluation, mental health assessment, social and environmental factors in addition to the medical evaluation that gets done. This comprehensive geriatric assessment is used to optimize the overall well-being and coordinate a care plan for patients. This is often completed in stages as it involves a team and multiple evaluations. Team members may include physician, nurse practitioner, social worker, pharmacist, mental health professional, and therapists. Nutritionists are not an uncommon team member depending on the circumstances. This comprehensive review of medical conditions, medications, their vision, hearing, weight, nutrition, mobility, and there's assessment for activities of daily living and instrumental activities of daily living. Cognitive function evaluation is involved and consists of tests for memory, thinking, decision-making, as well as executive function skills. Mental health considerations are another facet of this approach and cannot be left out, as there's details of the person's social and physical living environment that must be considered. This multifaceted analysis is also in purpose to consider the person's living situation, their social support, and their access to resources and review of safety. Mobility issues with fall evaluation are considered as well as the person's continence. Maintenance and control of bowel and bladder are very important indicators and can't be discounted or ignored. This truly is a thorough evaluation when someone gets this geriatric evaluation and assessment. Now I will go over some potential diagnoses that might have caused the event, and I already have mentioned a few of these. Reflex syncope is neurally mediated, a vasovagal or vasodepressive type of response. Common fainting is the most frequent cause of syncope, and nearly 25% of us will experience this once in our lifetime. There's a multitude of triggers such as dehydration, emotional triggers, but it's sort of the right time and right circumstance for this event to occur. Someone being caught off guard when they're already feeling bad, seeing blood, maybe during a blood draw or donation, getting an injection, seeing someone else injured, standing quickly, becoming lightheaded, standing too long, especially in hot weather, sudden or unexpected stress or a shocking situation, or acute intense pain. Some of these are just maybe caused by an ordinary event, but the preceding event that has led to that common fainting may indicate that there's not a medical issue. Orthostatic hypotension also is a common culprit of fainting, and that's when the standing the blood is too low and the person can faint. This event in particular is likely to occur to anyone that is dehydrated, overheated, anemic, or in acute pain already. Medications can be a big factor in this one as well, and we'll get to medications in a bit. Other possible causes that are less worrisome include prolonged fasting, sneezing or laughing, lifting something heavy or bearing down possibly during a bowel movement, possible having a coughing spell, or maybe even emptying their bladder can sometimes result in a syncopal episode. This in particular is known as micturition syncope, and it's a sudden drop in the blood pressure and heart rate. Typically this occurs in males right after urination and usually at night and begins around the 5th or 6th decade. Some patients may experience a syncopal event if there's pressure on their chest during or after exercise. Okay, so let's talk a little bit about drugs and medications. They can provide that right circumstance for syncope. Whether it's a prescription medication, alcohol, or an illicit drug, we have to consider the possibility of medications or drugs. Patients on diuretics or other medications that cause them fluid loss or electrolyte imbalance are at a higher risk for dehydration, and those disturbances can cause that syncopal event. Medications that affect blood pressure, nitrates for angina or other heart medications, possibly vasodilators, and some older antidepressants. Other medications that can cause a person to drop include muscle relaxants. As you know, if you've watched the pain series, I'm not a fan of muscle relaxants. Anxiolytics, opioids or other pain medications, some cold medications, and even antihistamines. And in geriatric patients, we cannot ignore or forget to look at their blood sugar medications. And I want to talk about blood sugar medications just for a couple of sentences here. Blood sugar medications are to keep your sugar within a certain range of not going too high. They do not prevent it from going low. Younger people can tolerate a low blood sugar. Older people do not tolerate low blood sugars as well. And so what we're trying to do is prevent damage to organs, whether it's their eyes, their nerves, their heart, their kidneys, from accumulating in the next 10 to 20 years. But geriatric patients over the age of about 60 or 70, don't tolerate low blood sugars well. They don't get an early warning system, and they will just faint and drop if their blood sugar drops too low. General rule of thumb is your blood sugar should never be within 10 of your age. So if you're 50, that's fine to have a blood sugar of 60 or 70, and you're likely going to tolerate it quite well. Most people would. But if you're 70 or 80 years old and your blood pressure drops to 100, you may not get any warning at all, and you're going to suddenly drop. And that's an acute event and can lead to serious trauma when we're trying to prevent something that's going to occur in 10 to 20 years. So American Geriatric Society does allow for more liberal control of an elderly person's blood sugars. There are numerous medical diagnoses commonly associated with syncope. Syncope can be common in many disease processes. We just talked about the endocrine, such as diabetes, but also Addison's disease or adrenal insufficiency, low blood sugar issues caused by other medical problems, thyroid issues, an adrenal tumor called pheochromocytoma, cardiac issues, abnormal heart rate and rhythm, whether too fast, too slow, or just unpredictable and irregular, or if the time between beats has been too long. Any one of these arrhythmia issues can lead to a syncopal event. Heart failure, structural issues such as heart valve problems, whether it's a leaky or a stiff valve, a heart muscle problem such as it's too stiff and it has the inability to respond to an immediate need, its compliance is less. So there may be acute need for an increase in output and the heart just can't do it. A heart attack or something called myocarditis. Any of those could result in a syncopal event. Another possible cause is sensitivity to the carotid sinus, and that's an area right here in the neck. This might sound like it would fit into the arrhythmia category, but when this is the culprit, it's usually because it causes that heartbeat rhythm change. This is an area right in here where there's a lot of lymph nodes, and it's very near that carotid artery. Stimulation to that area, for some people, can result in sudden and dramatic slowing of the heart. Ocular pressure, actually pressing on a person's eyes and performing a Valsalva maneuver, either one of those, can also mediate that same particular response because these three things will stimulate the vagus nerve. That's your 10th cranial nerve, and that can cause that heart rate to suddenly slow. Lung issues that result in acute hypoxia, such as a pneumonia or a blood clot, also known as a pulmonary embolism. Change in a person's blood oxygen amount and effect on their blood pressure. Pulmonary hypertension is a chronic lung issue, and in that category we would also include chronic obstructive pulmonary disease, COPD, chronic bronchitis, bronchiectasis, and pulmonary fibrosis. Folks with these problems are at a much higher risk for a syncopal event. With regard to neurologic issues, there are numerous neurologic disorders that can increase a person's risks, and up to 20% of migraine sufferers may have a syncopal event. That might surprise you. It's more common in females with migraines, but it does occur in males as well. Other neurologic conditions with elevated risk include seizures, Parkinson's disease, Guillain-Barré syndrome, Lewy body dementia, and normal pressure hydrocephalus. There are some other more rare neurologic issues, including Shy-Drager syndrome and pure autonomic failure. It might surprise you to learn that syncope is not a common presenting symptom of stroke. Most strokes occur in one area of the brain. The circulation and oxygen is cut off to a small area and not returning to that previous ability for circulation leads to cellular death in that one area, so it's not a global sudden loss with return. So cells in that area lose the circulation, lose oxygen, there's cellular injury and death, and that occurs within a few minutes. A syncopal episode is loss of complete circulation and oxygen to the brain for just a few seconds with immediate complete return of that blood supply. There are also some autoimmune disorders that affect the autonomic nervous system. Because these disease states affect the nervous system's ability to regulate heart rate and blood pressure, these people are also at higher risk. Some of these include Sjögren's syndrome, lupus, celiac disease, autoimmune autonomic ganglionopathy, and postural orthostatic tachycardia syndrome. These patients are all at a higher risk. For many, these patients have learned over time, though, the circumstances that are going to lead them to drop, and most of them have really become pretty proficient in not putting themselves in that situation where they might pass out. There are some non-specific syndromes that don't fall into any specific disease classification, and we can't overlook mental health illness events. Panic attack, acute anxiety, possibly a somatization event might be the cause of the syncopal event. Lastly, there are many possible geriatric syndromes to tease out. And the evaluation for this, as we spoke about earlier, is really complicated as well as time consuming, but it can be necessary. This is when that comprehensive geriatric assessment comes into play. Geriatric syndromes are multifactorial health conditions resulting from cumulative insults to multiple organ systems, significantly impacting the patient's quality of life, morbidity, and mortality. When cognitive impairment occurs, this will at some point result in a person having an inability to accurately interpret how they feel, as well as lacking the skills needed to accurately report the symptoms. When a person with cognitive impairment may state they feel fine or tell others that everything is the same as always, but on some level their body and mind know that things are not quite right. The person either cannot or will not acknowledge it because of their cognitive impairment. This list of murky issues also falls into frailty. And this is a process that is really difficult to find and difficult to test for. It's kind of vague and kind of ambiguous. It's a clinical state that's really important. It is hallmarked by several indicators: weakness, slowed walking speed, weight loss. They might include declining or low body mass index. Frailty can be thought of as a person being at risk or vulnerable. When a person has physiologic decline from multiple chronic diseases that are accumulated on them, it impacts their daily life. And these are frail people. Frail sounds so ambiguous, but you cannot discount it. It's a huge iceberg, and you don't want to ignore it. Frailty increases the susceptibility for fainting. There's a decrease in the resilience for those patients, and it's significant. This population is a very high risk for fainting and the health-altering trauma that can occur after that event. Delirium is a symptom, and it might be associated with syncope. Delirium is caused by so many other processes. The cause of delirium needs to be evaluated and determined and assessed, because if it can be stopped and intervened on, it's a must. This is an acute change in mental state from its baseline to a state of acute confusion and disorientation. There's hypoactive delirium and hyperactive delirium. In a hospital setting, it can be difficult to tell delirium and dementia apart without the assistance of the collaborative source. And I can't overstress the amount of information we as healthcare providers need and rely on. We have to receive that information from the collaborative source. We need information from the patient, but we also need and depend on that information from their loved ones and the people who know them. We don't always receive the necessary information from the people that know the patient well and attest to their recent cognitive status. For patients that come from a nursing home or an assisted living facility, there may not be anyone that can act as a collaborative information source. As a sidebar, it amazes me how many patients in the hospital don't have anyone with them when I'm rounding between 8 a.m. and 4 p.m. I understand that people must work and paid time off is precious and has to be cautiously used. However, when a loved one is in the hospital, the medical team would really benefit from being able to communicate with someone, and the patient would truly benefit from the presence of a person that they're familiar with. This has changed so much over my career. I used to experience people eager to meet me and be with the care team. They would arrive to the hospital early and be in the room when we entered, when we were on rounds. And they wanted to learn about the health status, take part in the planning and the future care of their loved one. It happens all too often now to me that I leave messages day after day and not receive a call back from the person's loved one. The hospital can be a dangerous and lonely place. Loved ones of patients that spend significant amount of time with them reduce the risk that patient faces from being hospitalized. The hospital is a dangerous place. And if you haven't seen the video on that, please review that video. In summary, syncope is when a person has an abrupt drop of their blood circulation and oxygenation to the brain that immediately returns. But this abrupt loss of circulation and oxygen causes the person to have that brief period of unresponsiveness, maybe just for a moment, maybe less than 30 seconds. But it's enough to make a person go down. Their blood pressure doesn't stop, but there's just not enough circulation to make it up to the brain to reach it. So the body's natural response is to try to get the head down, ideally at the same level as the heart, to allow the blood to get to the brain. There's a collapse. When a person faints and falls, please let them lie there for just a moment or two and not immediately try to stand them up. After the event, evaluation may be needed to determine the cause, and depending on the circumstances of the event, certainly if there's been an injury from the fall, then that needs to be evaluated as well. After one of the events like this, a person should be evaluated quickly and thoroughly. Sometimes there's an explainable event or a unique set of circumstances, and it might not be anything worrisome at all, and it might be quite benign. A fainting episode might be the first and only warning sign, though, of something that could be significant and brewing on the horizon. I hope you found this information valuable. It's also available on podcast. If I've missed something, please post it below for others to see. For those who came for the cookie, you deserve one if you got to this point. Enjoy. Thanks for being here. Bye now.